Okay, good afternoon, colleagues. My name is Professor Bonga Chiliza. I'm really glad that you've joined us this afternoon. This is our monthly interdisciplinary lecture series where we discuss topics that affect the brain, and we get inputs from psychiatrists, neurologists, neurosurgeons, and we are particularly pleased today that we have a neuroanesthetist. I don't know what that is exactly, but I'm sure Thube will tell us maybe about what that is. Dr. Ngubane is an anesthetist. She's interested in critical care. She is an academic at heart, to be honest, even though she's in private practice. She studied here for MBCHB at University of KwaZulu-Natal. She's a home girl from Umlazi. She has had some really interesting experiences in the last decade or so that I think has birthed an NGO, which is called Gugakahle. She'll be telling us hopefully a little bit about that story today and lighting fires for us to charge up and do a lot more when it comes to patient advocacy. So without further ado, thank you so much, Thube, for agreeing to do this for us. We really appreciate it, and we look forward to your inputs this afternoon.
Thank you so much, Prof. Thank you to everybody also for attending this meeting. I just would like to start by saying, obviously, thank you to you from the Department of Psychiatry. Thank you to Dr. Enika for this lovely collaborative effort that you've started, which I think is an amazing initiative, just so that we all get in shoulders to the wheel in an interdisciplinary manner to make our efforts heard and seen and do something about making a difference in patients' lives. I hope this will grow from strength to strength, because I really think it will be the birthplace for many things, wonderful things to come, research and things that will make a difference in our world. Without taking much time on this, I'd like to get into the presentation, because you've done most of the introduction really about me, and I'd like to leave time also for us to discuss pertinent issues. I'll switch off my video as I share, just so that, as I share my screen, just so that I'm sure that my network is holding up nicely. So I'll just start sharing my screen. Please give me an indication if you can see it. Can you see my screen?
Yes, it's very beautiful. Thank you.
Thank you so much. So the topic that I thought we need to discuss today is bridging the gap in dementia care. Obviously, this is a very broad topic, and it's a very big issue that has many facets and many faces to it. But I think let's just tackle a few issues as we go on today, and we see how we fare as we discuss further. So disclaimers, as you have put, I'm neither a psychiatrist nor a neurologist, but what I am is a philanthropist, really, with a deep passion for making a difference in humanity and people's lives beyond just my medical career. By my profession, as Prof has kindly mentioned, I'm an anesthesiologist with a very deep interest in neuroanesthesia. And I'm also an intensivist as well. And I've spent some of my years in neurocritical care as well. So that's where the basis of, I've always loved the brain and brain function, even in my anesthesiology duties. So this is just a branch of what I've already been in and I've already loved for all these years. Today is a particularly special day, and I feel honored to be giving a talk to all of you on this day, the 1st of October, because some of you may know this day is a day that was already ordained by the United Nations as the International Day for Older Persons, just to highlight that actually we need to be cognizant and really be aware of the special group of people that the older and aging generation is. It also happens at the back of a month that we're coming from, which is World Alzheimer's Month in September. And some of you may be aware that the 21st of September was World Alzheimer's Day. So we really need to be aware of what's happening around us and what efforts are being made in actually making sure that our aging population and also persons living with dementia and Alzheimer's are subjected to. I also need to highlight that the World Alzheimer's Report was released last month on the 21st of September. The theme for this year was a journey through diagnosis of dementia, which I actually think was quite an important topic to tackle. As you can see, what I'm going to talk about today with dementia and dementia care and the challenges that persons living with dementia go through. So I encourage all of you actually to read through this report. It's a lengthy report, but if you take it section by section, you'll see how much benefit this is going to be to all of us. My lecture outline today, what I'd like to cover is just to give a brief introduction on who Ngubane nonprofit company is, and I'd like us to discuss also what the aging population is and what they are going through. I call this actually the looming storm because of what aging and the growth of the aging population is. And then I'll go through what I call the silent pandemic, the dementia crisis. And then we'll discuss if aging really matters and if aging really is something we should stress about, or if dementia on its own matters. Then I'll touch on advocacy amongst healthcare professionals, which is what I think is a pivotal role, and then we'll have a discussion after that. I'll try and be concise enough so that we have enough time to discuss issues and bounce issues around amongst ourselves. Then, sorry, my screen just froze for a bit, sorry about that. So Ngubane nonprofit company is actually an initiative that we started out of a very painful journey, actually, that we on a personal level, that I and my siblings have gone through, and with a journey of dementia with our mother. It's a humanitarian organization which aims to educate about strategies to promote better aging. We actually would like to promote aging without chronic disease. We really would like everybody to age without any ailments. When it's time to go and depart from this age, we really like people to depart without any diseases. But seeing that this becomes a challenge, if people do age with disease, we would like them to actually have well-controlled disease. We focus our efforts on education about dementia, which most of you will know, dementia is a major cause of disability and dependency in our senior citizens. Our vision in Ngubane is to eradicate dementia during our lifetime. I know somebody would say, oh, that's a monumental task, but I think this is a fair vision to have, seeing what the effects of dementia are amongst our people. We want to eradicate all dementia and modifiable risk factors in the aging population with better management of existing diseases. We want to also collaboratively formulate a viable and practical dementia action plan for South Africa. This I must stress because I find South Africa to be a special a population which is multicultural and really with spatial characteristics. So we need to find solutions that are Afrocentric, that actually cater also for a multicultural nature in our society. We also want to have affordable and accessible care for persons living with dementia, and also to promote coherence amongst all dementia action, care and treatment groups within South Africa. Our mission is quite wide as well, because we want to create dementia awareness through our educational campaigns. We want to educate about preventable strategies for modifiable dementia risk factors. We want to create a support structure for caregivers, families, and community members of persons living with dementia. We also want to formulate solutions that are suitable for our South African setting. In addition to that, we also stress the point of solidifying our collaborative efforts and support from community leaders, traditional leaders, indigenous African healers and faith-based healers, and also governmental organizations with other NGOs as well, in formulating a concrete solution for persons living with dementia. This I must actually stress, because most of you colleagues would know that in our African setting, when a person starts having symptoms that are suggestive of neurocognitive decline, you seldom see people rushing to a Western doctor. Most of the time, people would seek assistance from their faith healers, traditional healers, indigenous healers, and people that practice African spirituality, which is why I think this is actually quite important and pivotal, that we all need to work together in solving this neurocognitive decline problem that's engulfing our aging population. Notwithstanding that neurocognitive decline doesn't happen only in the aging population. Moving on from that, we want to also have collaborative efforts with academia in responding to pertinent issues and questions relating to dementia, because there's a world of research effort that needs to be embarked in solving this problem, which is why actually we are here and excited about this initiative in neurosciences with UKZN. Our values in Gukagahle, I call this our values called dementia with a touch of hope. This is just to give an indication to people of who we are, what we stand for, and our values. We are dedicated in carrying out our duties in dementia care. That goes without saying. We want to encourage and inject enthusiasm in everybody, actually, not just the aging population, in everybody that is alive today, to care about dementia and aging. We want to motivate persons living with dementia, their families, caregivers, that a fulfilling life can actually happen. It's actually possible when you are living with dementia. Our most valued effort also is to educate continuously, to nurture and protect our seniors and care for them, and reignite the spirit of Ubuntu within our communities, which I find is sort of lacking nowadays, with lots of senior citizens being abused, being neglected, and not being taken care of. We want to also promote ties and coherence with communities and within communities to encourage strength and support within the body of community body itself to support one another. We work with integrity and honesty, and we want to also always be altruistic in upholding the rights of the vulnerable and aging population. Most of all, what I find drives us a lot is that we want to instill hope in everybody that's living with dementia, their families and their caregivers. Because some of you may know, dementia is very hard to deal with. Taking care of a person living with dementia is tough. It's hard emotionally, physically, and it's hard on finances as well. But we want to instill hope in people that actually you can still care for each other and find a solution that is centered to the person and the family themselves. So our big why on top of everything else, why do we do this as Ukagahle? I found that our road with our journey with our mom, my siblings and our mom, our family through dementia took a very windy, difficult, tough road. It was hard because our mom, some of you may know, our mom had young onset symptoms of dementia, and the road was long. So it was hard, it was long, and I started asking myself these questions that, why is it so tough? Why is it so hard? When the diagnosis was finally made, actually, I remember just feeling like I was standing at that dead-end Cape Town bridge and just not knowing where to go. I asked myself, why was this really happening to us? Why was this so difficult? Why was it happening to our beloved mom who had spent her life as a specialist nursing sister in the theater area, so a highly functional individual? Why was this happening? Why was it happening to our family? Why did it take so long for a diagnosis, a concrete diagnosis of dementia to be made? And, I started asking myself, if dementia has no cure, what does it mean for us as a family? What does it mean for our mom? And why was it that, we had so many investigations, we traveled through so many healthcare professionals, and seldom were we given hope and a plan to say, this is what you need to do, step 1, step 2, and post-dementia care would take this form or would take this phase, and you need to expect this and expect that. And I must say, as a medical professional, at the back of my mind, all I was going through is, hey, I don't remember going through dementia, a lecture in dementia at medical school. I'm like, was I paying attention in class? I remember I was an avid student, but I just don't remember it being stressed to me that this is a real life issue. So as I felt myself standing at the dead end with the report of our mother having dementia, I started just, getting into a whirlwind of emotions and questions and everything else. So sorry, somebody saying something? Okay, so at the end of it all, I asked myself, why should we all care? Why should we care? And I'd like to pose this question actually to everybody attending this lecture today. Why should we care? So I think all of us actually should care, because as we listen to this conversation today, we are all aging minute by minute. The second reason why we all need to care is that there's still no concrete proof that this person will get dementia, that person will age without dementia. The third reason why we should care is that there's still no cure for dementia, and it's a major cause of disability and dependency in aging adults, as we've seen. The World Health Organization reported this. Also, the other reason is this is actually something that a lot of people in the African culture still don't know about, and it's costly, very difficult care as well. So let's move on now to what I call the looming storm, this aging, because it's fast approaching and I think it's engulfing us, but I don't feel we're moving fast enough to cater for this storm that's coming upon us. Let's just go through the statistics, South African statistics of the aging population. I know I'm quoting 60 and above, but you know that we start worrying essentially at 65 and above, even though you get young onset dementia in itself. In a South African setting, more than 5.5 million of people are over the age of 60 years. The majority of these people are in Gauteng, with almost a quarter of the total being there. KZN is the next following province that has the highest number of the aging population, which is why I'm excited that I'm delivering this talk as well with you, KZN. The Northern Cape, as you would imagine, has the least population of people that are living, that are over the age 60 and above. It's just a graphic representation of the actual numbers of the aging population. Now, I just would like to stress as well and bring your attention to this fact that the United Nations has been tracking the growth of the aging population, the seniors at 65 and above in sub-Saharan Africa. In 2019, the projections were that they're sitting at 35 million, and there's a projected growth of 218%. By the year 2050, we'll be sitting at 101 million seniors that are living in sub-Saharan Africa. This is a problem, actually. The WHO released this report as well, the Global Action Plan on the Public Health Response to Dementia, which is a plan for all member states that were meant to make plans between the year 2017 and 2025 on the action plans. So they have projected that globally, there's about 50 million people living with dementia. This figure is set to triple by the year 2050 to 152 million. Remember that the projections or the estimates are that every 3 seconds, somebody in the world starts having dementia symptoms. That puts us in saying that there's 10 million people that will be diagnosed with dementia every year globally. Remember that also dementia care is very costly. The figures that are protracted now, in 2030, there will be an expenditure of about $2 trillion in this type of care. So this is quite costly. In our South African setting, what makes the situation very challenging is that, one, our population is aging at a fast pace. Well, somebody would say this is a contradictory statement. Well, how can you age at a fast pace? But I think we're not paying attention enough to our subset, this special subset of our population. What compounds the matter even more is that the prevalence of cardiovascular disease and obesity in Africa is escalating. HIV and aging in our population as well is fast becoming a problem. Some of you will recall that Dr. Taylor made a presentation on this about 2 months ago as well. Poverty makes this even more complicated. There's poor access to healthcare. There's lack of knowledge about the disease entity that is dementia. But I also would like to put in the mix that COVID-19 has put a huge spanner in the works as well in the care for our aging population. The insidious disease process and pathology preceding the clinical symptoms of dementia, which takes about a few decades before you get clinical presentation, makes this quite a difficult thing as well. So I ask again, does it all matter? And does aging matter? Does dementia matter? I would like us actually to all honestly think about these questions. We need to stop adopting this notion or this tendency of putting our heads in the sand, we need to come out and actually honestly answer these questions. My clear question is to say, yes, it does matter. Why does it matter? The recent report that I spoke of, the World Alzheimer's report released last month, said that over 75% of persons living with dementia globally are undiagnosed. Approximately 90% of persons living with dementia in low and middle income countries are undiagnosed. This is a huge problem with our South African setting. So there's an urgent need with saying this, that we need to break down why there's barriers in diagnosing persons with dementia. I've got a lot of postulations because I've toyed with these questions for many years in my mind. But today I'd like us to deal with one big issue, which is stigma. Stigma is actually one of the major barriers to early diagnosis for dementia. Why do I say this? Let's first define what stigma is. Stigma is a set of negative beliefs that are often discriminatory towards a person. This set of beliefs deprive the person of their dignity and often places shame and disgrace on the person. This results in an ailing person being viewed in a negative light and being isolated from full participation in society. So you get why I say this is actually a major barrier to diagnosis. Stigma often leads to discrimination, which is defined as being treated in a negative and unjust and prejudicial manner due to a condition that you're living with. You will note that stigma and discrimination has detrimental effects in anybody, particularly in the vulnerable aging population and persons living with dementia. We will all agree that stigma is a very complex issue. We in South Africa have a very painful past, which we know racial issues have resulted in stigma. So you will understand as well that with the deep roots of any stigma towards anything, there is a problem. So stigma towards persons living with dementia is rooted in three factors, actually. The stereotypes that we carry about what dementia is, what it means, and the notion that we've seen in movies of people, or portrayed in media, people living with dementia are like this, are like that. That causes the stereotype that perpetuates the stigma. The discrimination against persons living with any disability actually perpetuates the stigma even further, causing prejudicial responses towards them. So what do I say are contributing factors to stigma? One is the person themselves, self-stigmatization. If somebody has memory trouble or somebody can see that they've got behavioral issues, then they would think, oh no, I can't come up, I can't seek medical attention because people are gonna think this or that of me. Family can become a big factor as well, or contributor in the stigma attitudes. If, say, a parent has been the breadwinner or has been a certain person with a certain social standing in the community, when the behavior changes, then family may be the first people to actually point fingers. Why is mom doing this? Why is dad doing this? Why is grandma doing this? Why is grandpa now changing tones? Why is the language changing? Friends as well start becoming an issue, because when things are not going well, some friends actually move away, leaving the person living with this condition actually quite isolated and quite lonely, and compounding the problem even further. Members of society and community, for instance, in our churches, in our stokvels, can start having behavioral changes towards the person dealing with the problem. I find also in South Africa that service providers can be an issue. If you're standing at Pick n Pay and there's a granny in front of you that's struggling with memory or cognitive issues or behavioral issues, the first thing for people to do is be impatient, say unkind words, or point fingers at that person instead of being more understanding. Medical professionals, I put this in red because this is what I'd like us to think about. It's a major problem, and it's what we as medical professionals need to think about. Why do we have negative or attitudes that are not pro-helping when we deal with persons living with dementia? Some of the stigmatizing attitudes are worse in the following groups: amongst people with limited information about dementia, people that have limited access to persons living with dementia. Younger individuals tend to have more stigmatizing thoughts and attitudes and more impatience. Men are said to have more stigma when it comes to this issue. There's also an important thing about ethnic and cultural ties to certain diagnoses. Dementia in the African context has a lot of thoughts and stigmatizing attitudes. For instance, the first thing is, oh, if granny is suffering with this, then she's paying for her sins. Or if grandpa has this, then it means he was practicing witchcraft. People are getting abused, killed. We've seen in the media lots of reports about our aging population and our senior citizens being killed, being raped, body parts being taken for muti, all sorts of unkind and criminal elements coming out of this. Culturally, other cultural groups also say the aging period is a period of isolation. So when you get old, or you get to your senior years or golden years, you are said to then be made to sit at home, isolate, which actually further compounds the problem of neurocognitive decline, because how can you keep active and your brain active when you are socially isolated? Stigmatizing attitudes also have been reported amongst healthcare providers, as I've said. This is a problem, and I'd like us to think honestly about what our attitudes are towards the situation. I have my own postulations, which I've put forward, and maybe we can discuss at the end. The stigma issue amongst medical professionals towards a neurocognitive decline or patients dealing with this is probably rooted in our medical training, what it's centered or mostly has been centered around. We've been taught to diagnose disease and to treat disease. So it's you identify a problem, you treat it with medication versus prevention. We medical professionals have certain attitudes towards sort of an illness that has a cure versus an illness that has no cure. We really have not been skilled enough to say, how do we deal with persons that have ailments that have no cure? Does it mean that we say, oh, well, there's no cure for you, then there's nothing we can do for you, which is in part what me and my family sort of experienced in a way, because you get the diagnosis, but then when you ask, so where do I go? There's no concrete post-dementia care plan. Some of the answers, because we went through a lot of medical professionals, some of the answers would be, oh, Google a care home, or Google a support group, Google so we ended up just Googling our way along to say, okay, I don't know if these people will be right for us, but then Google is all I have. I need to just then phone, my sister would go to some of the places to check it out. But from a medical perspective, there wouldn't be a concrete plan to say, okay, your mom has this diagnosis, we can't treat it now, we can abate some of the symptoms that are troublesome, but go here, this is how they're going to help you, they're reputable, we know them, X, Y, Z, you know. So the other issue that plagues medical professionals around dealing with diseases or ailments with no cure is the perceived futility of care. Lack of knowledge about dementia is actually a major issue, believe it or not, amongst medical professionals as well. There's a segmented approach to medical care versus the holistic patient-centered care. There's also a lot of fear element around persons living with dementia because, you know, like I said, media portrays it in a negative light as well. Yeah, sure, somebody living with dementia will have a catastrophic reaction sometimes. There will be, you know, hallucinations and behavior that is problematic. So there's a lot of fear around that element, and medical professionals, I find, if you don't have a drug to sort that out, then we feel a lot of inadequacy as well to say, well, I can't do anything because I don't have a magic pill to abate this. There's an inability as well to perceive people living with dementia as human before the disease itself. This you see most of the time when persons living with dementia go to a doctor. The tendency is to not speak directly to them because, oh, well, they don't even understand what I'm saying, or to speak to the accompanying people and to make a plan that does not involve them. Yes, we know they don't understand, but sometimes to show the human element as well, they need to be roped into the care plan as well. I find also maybe one of the major issues that plague the medical profession that we're in is to probably say there's been a lack of willingness to collaborate with other non-Western or non-medical supportive structures post-diagnosis. I'm actually very excited and very glad because Professor Kiliza is one of the most open-minded professors and the most progressive people I've ever met, because the recognition that something bigger than Western or medical care that we can offer can assist in the people that we diagnose with this condition and we send back to the community to coexist with others. So how can we enable this and enable assistance for them? Sorry, my screen has just frozen. I think I've just spoken too long on this topic. So can I just stop sharing and come back and reshare? Sorry about that. I hope you are still there.
We are.
Okay.
We still are.
Okay, all right. Please hang on a second for me because my screen has just frozen. Can you see my screen?
Not yet, Doc.
Sorry, Zoom will do this.
Something is loading. Something is loading. It's back.
It's back. Okay, and it's not moving on my side. Oh, man. Oh, no, sorry. Please hang on for me. Oh, why? Oh,
I
is
just
it moving?
apologize in this virtual world.
Oh, is it back? Can you see my screen?
We can see.
Yes. Okay, let's carry on.
See the graph.
Okay, great. Okay, so this graph actually forms part of the World Alzheimer's report that was released. Just speaking on what I was talking about the stigma attitudes, the beliefs by clinicians that nothing can be done, it's futile care, and that other challenges being lack of access to basic assessment tools by clinicians as well. You'll read the report and you'll see. I'm trying to catch up on the time as well. So part of the report was that to do a short survey, an online survey that they did of 3,542 clinicians, persons living with dementia and carers as well. They completed the survey so that just to get an idea, please bear in mind that this was obviously a small survey. Most of the participants were first world participants, so you can't translate it directly and give it the South African setting or flair as well. But what's important that came out of this is that only 45% of persons living with dementia and their carers felt they received adequate information about dementia. Only 45%. So I think this is a challenge. So think about what our South African setting would say in this issue. Are we providing enough information to persons living with dementia, their families and their carers about this? The key barrier to diagnosis as identified by persons living with dementia were the lack of access to trained clinicians. I know there's major challenges even with the South African setting. We don't have enough geriatricians, we don't have enough psychiatrists, we don't have enough neuropsychiatrists. Goodness, you know, I count myself amongst the elite. I know Dr. Taylor. We don't have enough of Dr. Taylors in the world. We don't have enough of Professor Kilizas. We don't have enough of geriatric psychiatrists, Dr. Sihle, you know, so we're lagging behind. There's fear also of diagnosis. Persons living with dementia, once you start having memory and behavioral and all the other problems associated with dementia, there's issues with that. People fear going to a doctor for a diagnosis. The cost element as well is an issue. Key barriers to diagnosis as identified by clinicians in this survey were lack of access to specialized tests. We know this is a reality for us as well. There's lack of knowledge in making the diagnosis. We know this is a reality. And the belief of futility, I can't stress this enough. The fact that somebody has dementia does not mean that there's futility in care, in holistic care as well. So challenges related to receiving dementia diagnosis are lack of information about dementia, as I stated, lack of language and culturally appropriate information, as I stated, and lack of information about dementia in the population with other disabilities, and lack of information about dementia in the younger population, younger meaning less than age 65, and the lack of access to healthcare as well, and specialized tests and financial constraints. There's reluctance as well to seek medical advice. This is also another graph that I'll ask you to look at in the report. So let's come to advocacy in health care professionals. I actually think healthcare professionals play a pivotal role in advocacy and the role in this outside of the medical profession. Dementia is a complex medical, social, and ethical and economic issue. It's a conundrum. You know, everybody needs to be involved, and medical professionals are the missing link in most of the care or post dementia diagnosis care. The problem can't be solved in isolation. It can't be an us versus them approach. There needs to be a shift in our mindset as medical professionals. Everybody involved in healthcare needs to have a shift in mindset about dementia. Oh, my screen is frozen again. Please, I apologize again. Prof, am I gonna get extra time for these challenges with the freezing screen?
Yeah, definitely. Yeah, please keep going today.
Okay, so I just would like to show you the screen as I go along. Okay, so one moment, please. Okay, so you can't see my screen, I guess. I'm still frozen.
No, nothing
Yeah,
is
no,
on.
nothing.
Okay, so let me just carry on with the presentation. So I think you know what advocacy would address certain issues like, or answering questions like, how can we make access to care easier for persons living with dementia? How can we make the path to dementia diagnosis simple enough for persons living with dementia, their families, and also their caregivers? How can healthcare services be more accessible? Is there a role for mass screening for persons living with dementia, sorry, not living with dementia, but with cognitive impairment in communities? Persons that are starting to identify changes that are suggestive. Can we have validated tools like we've spoken before, Prof, in our South African setting? So how can also we make cost of care more affordable? I'm just throwing around the ideas that I think as medical professionals we need to look into. So in the absence of cure as well, how can medical professionals optimize the quality of life of persons living with dementia, their families and carers? The role of modification of junior medical curriculum as well, to make them more dementia aware and produce more dementia-friendly junior doctors. So instead of doctors that won't know what to do, we need to have doctors that are aware of this. We need to also have tools to identify stigma throughout the path of dementia care and have culturally acceptable and affordable issues around placement homes, because we know in the Black population, this is a major debacle, taking a parent and placing them in a care home. We need to cultivate dementia-friendly communities also to allow for keeping persons living with dementia in their communities for as long as possible. So I just want to say, dementia is a major issue for all of us, not just for some people. It's for all of us to hold on to each other. Can you see my screen?
Yebo, we can see it.
So sorry, I've skipped a few slides then. So this is for all of us to handle, not just a specific group. So we at Gukakahle have made a number of initiatives as well to say, you know, how can we tackle issues surrounding dementia? We've taken a lot of educational roles as well to kind of say the storm is coming. We need to pay attention to this. We do a lot of educational efforts with radio. We do a lot of educational efforts with our social platforms and our social media on Instagram at Gukakahle and on Facebook, Gukakahle. We also have taken the initiative to say, let's publish a book that it describes what dementia is within our African, one of our African languages in isiZulu, because we do need our people also to understand what this entity is in a language that is suitable for us. We also have distributed this. Around 800 copies have been distributed to people that want to know about it. We also have, as Prof, you know, we've discussed, have lots of inter-organizational collaborations as well to tackle this problem. Lots of discussions regarding community, African spiritual healers, faith-based healers as well, particularly for our Black community, because we need to tackle this together. As I close, I just would like to acknowledge again, Prof. Tiliza, Dr. Enika, and the whole neurosciences team at UKZN, that this is an amazing initiative. And I think lots of great initiatives are going to be birthed from this. Also, I just would like to acknowledge all the care groups and advocacy groups that took the time to join today. I'm not sure if Alzheimer's SA, Dementia SA is part of the session as well, but they said they've joined. Also, there's lots of other advocacy groups that we touch base with, Besi Makhathini Foundation, which are people that are doing great work with Sisetu Makhathini. Also, there's people that are doing lots of work in their communities, teaching, Mrs. Bongi, Bakis. There's different foundations as well that deal with stroke, depression in women as well, Miss Nedi Ngasana. So all of those people are doing great work, but I say we need to tackle this problem together, because it's pointless reinventing the wheel per se, because this is a huge problem to tackle. We need to all collaborate and work together to say, what can we do together? This person does this, that person does this, that person does the other. You know, there's great initiatives as well by one of our alumni, I will claim now, alumni, Dr. Stombo Makungo as well, who runs the GOGO unit, which I was quite excited to hear about, the geriatric orthopedics and general osteoporosis unit in UCT. That's an absolutely amazing initiative, because we need to recognize Ogogo nomkhulu are not just, you know, a subset like no other. They are a special group of people that need special attention and special medical care. You don't take a neonate or a baby that's been born yesterday and you take them to an adult doctor. You take them to a pediatrician. So why should we then deal with Ogogo nomkhulu as if they don't have special needs that they need to be catered for? As I close, I also would like to say, you know, we need to all be friendly towards persons living with dementia. You know, use kind language. I have a big thing, you know, for this talk, I use dementia just for understanding, but I like terms like neurocognitive impairment, major neurocognitive impairment, because it says to people, it's a cognitive decline, it's an illness. It's not, or it's not that the person is just malingering and pretend to be ill. So we need to be kind, we need to be gentle with our Gogo, we need to be gentle with Omkhulu, and work together in spreading the word to say, you know what, neurocognitive disease is here and we need to do something about it. Thank you so much, everybody, for this. I'm sorry for the slides that didn't show. My screen keeps on freezing. I'm sorry about that.
No worries, Thube. So if you can see your face again, that'll be great.
Oh, yeah.
Thank you very much, Thube. This is a fantastic presentation. We really appreciate it. I wanted to ask you the first question, perhaps, and then allow people to also ask questions, and we will definitely go on a little bit after 1 o'clock. Why do you think that there isn't proper integrated interdisciplinary care in the private sector in our country? In other words, even if you have money, you're not able to get really great care. That for me, I found quite fascinating.
It's a Prof, you know, I don't have a straight answer to this question because it's a very complicated question to answer. Because I think, firstly, recognition that when you are a specialist, you're not a single organ doctor. I think let's start there, because unfortunately, even though we specialize from our junior degrees, we become specialists, some of us subspecialize, you know, people tend to lose the integrated holistic patient care and tend to focus. If you are a brain doctor, you focus on the brain. Well, I don't care what happens to the kidneys, you know. If the person has you know, an issue with the lungs, well, you know, I just look at the lungs, not the brain, you know, which is why possibly for me it's been quite an important issue, because my work, my line of work in anesthesia is that I have to look at everything every day. You can't put anybody to sleep without looking at everything, because you need the person to wake up. So that's been the basis of to say, you know, let's take, there's a holistic person. The person is the whole. We need to look at them as such. So I think in private practice, there is the challenge to say, oh, my line is nephrology, my line is pulmonology, I'm not looking at anything else, lest I step on toes. So we need to sort that out as well, to say the patient is still a whole, you know, they're not gonna walk away with a kidney whole, they need to walk away with themselves whole, with brain functioning properly as well, you know. Because another challenge that I see, not just in the medical space as well, in society as well, the fact that the brain is within the skull and we can't see it. That's why I think one of the challenges is that people don't recognize that something is going on within the brain. So the fact that normally we don't understand, because we don't see bleeding anywhere, you know, so people don't understand, which is why in the book I've illustrated that actually within the skull there is the brain, and the brain has areas highlighted in color to say, people don't say, Uma, when she doesn't remember today and she remembers tomorrow, that we are Zenzis. And no, the light was on yesterday, but today it's off in that area of the brain. So we need to have that understanding and coherence.
So I'm going to ask you some questions from the chat, and people, please feel free to also raise your hands and talk. The first one is from December Mbanza, who's one of our excellent occupational therapists at UKZN. And his question is, do you have an online copy of your book, Kukagaki?
Yes,
your
I
book.
do. Yes, I do. Yeah, we'll chat. I do. I'll give it to special people.
So December, I don't know if you can unmute yourself, because I think the question of the role of occupational therapy in dementia is very important. And I was just wondering what you are teaching your students at UKZN.
Thank you, Prof, and greetings to our lovely speaker. We appreciate the very insightful presentation that we received today. I am truly inspired. I was very much struck about the 45% response that postulates that people are not informed or given enough information around dementia. You know, which speaks to what, as occupational therapists, what we do when we have a patient with dementia. One of the key things is education of the family, especially because our intervention is always looking at the environment and the person interacting with the occupations within the environment. And for dementia care, their social environment is very important, and family or caregiver become our key focus in the intervention. As our patient with cognitive decline, they may not comprehend much in terms of education and understanding the diagnosis and what is happening in their lives. So I think it comes back to what Prof was asking about the integration and working collaboratively of the medical team with all the person that is relevant, because that's the challenge that we usually face as OTs, that some of these patients are not referred to OT, and they are managed in whatever space that they can be managed. And not that I'm selling my profession, but this is what we teach students, that it goes to the extent of visiting the home and making adaptations to the home for this particular individual to be more functional at home, despite of the level of decline that the person may be in at the time. So I think what stays in my mind a lot from this presentation is the fact that we need to strengthen the collaborative efforts, because there is more. We can decrease that 45% of not being informed about the diagnosis, because we truly understand that in terms of the diversity of our professions, doctors are usually having a very long list of people to see, or long queues of patients to see. Not that OTs do not have many patients to see, but the nature of our work and intervention and our outcomes of intervention forces us to go to that extent of even sitting down with the family and spend 30 minutes educating them about the diagnosis. So I'm challenged the findings, they challenge me to say we need to do more as OTs in terms of education. So I would really like to have your book, and if your copyright is flexible enough, maybe a person can use a little bit more in terms of educating the patients and our students in what they do. But I do have a question that I want to pose about, I don't know up to what extent you have gone with your organization in the rural context. You touched on it a little bit, but the challenge that we usually face in the rural context when we try to teach dementia is that it is just perceived as this person who's you know, it's like, no, they don't need the intervention. They're just getting old. And then another swing to it is that some people are misinterpreted as by a tagata. That's why they're talking to themselves. That's why they're wandering off. That's why they are found in neighbor's house naked at night, because they left their home and they don't know their way back to the home. And there's a lot of abuse that end up happening, and only to find that the person is just having dementia. So education to all social.
So December, just for the sake of time, my brother, the question is clear. So maybe we can allow Thube to respond to that question. Thanks for your inputs.
Thank you.
Right?
Okay, so definitely, as Prof, you'd know that our issue about education is big, and Gukagahle has been quite specific, not excluding people that can understand English of other race groups, but we've been quite deliberate and specific to say the challenge is extremely severe in native speakers, people of our African people as well, because of the deeply entrenched belief system that, dementia is because of X, Y, Z. So that's why we've been deliberate in saying, let's write the book ngesizulu so that umuntu ezo-understand, ezobona kahle ukuthi this is not what it's been perceived to be. So the long and the short of it, education and collaboration is part of the work that we do in the mix.
Yeah. There's a question from Immaculate on the chat today. Uti, what are the early signs of dementia?
Okay, so that's a great question, because I find a lot of people get confused with, what do I look out for? Dementia is a complicated issue with of neurocognitive decline. I should actually be very careful, because I don't want to encroach into Dr. Taylor's space, because maybe he should answer this question, because I don't want to be lay about it. But the long and the short of it, Immaculate, is that, one of the most commonest symptoms or signs for dementia is memory loss. Not just the memory loss, which, I forgot where I put my keys, now I remember. Memory loss that disrupts the way of you conducting your life. So memory loss that disrupts the way of living. Behavioral changes also become part of the symptoms that you look out for. Also, some of the people that experience dementia, there will be mood changes as well. Umundu is forever now not happy, dysphoric, depression as well in the aging population can also be one of the earlier signs and symptoms as well of dementia.
Excuse me.
So
thanks. I think those were nice and simple. I see Zetu has joined us from London. And we're talking about hair education. I don't know if Zetu, you want to say a few words? She's been typing a lot on the chat.
Yes. Hello. Where? Hi. Unmute. Zetu.
Not sure why she's not unmuting now. Okay, she is, anyway, her message on the chat. Today, are you still there? We lost people. Hi, Zetu. I think we lost.
Yeah, sorry. I'm sorry. Can you hear me?
We can hear you now.
Yes,
yeah.
hi. Sorry, I've said good afternoon. Sorry, what I wanted to say, thank you so much for the wonderful presentation. I'm just sitting in the office listening to it. What I just wanted to say, we cannot forget carers here. Without the carers, we can never get anywhere because they go through so much. And I think we at BMF, we ensure that the carers are supported because they become depressed themselves and they're so stressed because it's relentless, this challenge. So I think it's very, very important to make sure that we look after them. We teach them how to sort of take care of themselves so that they can continue to look after their loved ones. So that's all I wanted to say. Thank you so much again, yes.
That's a very important comment. Thank you so much, Zetu, as well. For that wonderful comment. Sure, that's one of the topics that I deal with as well on our social platform to say, okay, how do you take care of yourself as you care for your loved one with cognitive decline, because some of the studies have shown that people that take care of their loved ones who suffer from cognitive decline actually end up having life-threatening ailments themselves. And some of the persons have actually been found to die even before the person with dementia dies. So it's a very important topic, because you find people are caring for their loved ones. They end up getting so stressed, they get hypertension, they get diabetes, they get cardiovascular disease, they stroke, they die. They get a heart attack, they die. While all they were trying to do is try and to assist the person that's living with dementia. So it's a very important comment. Thank you so much, Sister, for that.
So I think we need to end now today. Apologies for the technical glitches.
Thank you.
But I think it's almost 15:15. So yeah, maybe the last comment for me is that particularly perhaps to our registrars, the junior doctors, if you could just tell us a little bit about this thing called activism. I know that our junior doctors are afraid that perhaps if they speak out too much, they'll be targeted. Like whistleblowing in this country, if you say anything, if you pick up any issues, your life is at danger. So I'm just asking, your life is not in danger yet, right, to me? And would you encourage our junior doctors to also join you in this activism journey that you've started?
Yes, I definitely, Prof. I'd love them to join. Actually, maybe I must offer to make visits and give some encouraging lectures to them as well. And we have a lengthy chat about it. We must pick up, because our patients rely on us for their well-being as well, and to look after them holistically, not just one organ as a whole. Yeah, I see my sisters as well. I hear, we all in this together in handling this very difficult journey with our mom. So thank you so much, Kaya. I see you. Thank you.
Yeah, so thank you so much. We really appreciate it. And we've recorded the lecture, so it'll be available on our website, and we'll share it with you and other colleagues that would like to have it. So thank you very much, registrars, colleagues, people that joined us today. We appreciate it. And the next talk will be something a little bit different as well, around neuroscience, at the beginning, the first Friday of next month. Thanks, Dr. Ngubane.
Thanks, bye. Bye.
Cheers.